Alrighty, well, welcome everyone to our second Transforming Pediatric to Adult Healthcare Transition in Minnesota ECHO series. We're very excited to have you all. We would love for you to introduce yourself in the chat so that we can get to know each other more. We welcome cameras on so we can get to know each other. And of course, there will be lots of interaction as we go throughout today's very quick and fun-filled session. So, next slide. The aim of this Healthcare Learning Transition Collaborative is to transform Minnesota healthcare systems to provide equitable, accessible, and trauma-informed pediatric to a healthcare transition for all Minnesotans. And hopefully, since we have other folks from out of state too, to extend beyond just Minnesota. We could not possibly do this without an incredible group of people behind the scenes here. And this includes our funders, in collaboration with Got Transition, the ECHO Institute, our incredible core faculty and steering work groups. Next slide. Here is our core faculty listed. Everyone will be here with the exception of Maria Medina today, but will be present at nearly all of the sessions to really help steer conversation and stimulate discussion. Next. We also have a much greater steering work group who have helped us design the sessions, advertise, make sure that we're reaching a broad breadth of experiences and different facets of transition care. This is a continuing medical education event. So all of this information about CME is included on our website. Next slide. And you'll get a certificate for participating equal to 1 contact hour that you can use to present to your different boards. In order to maximize our learning collaborative, we would love for you to use your video, to mute your line unless you're speaking. If you want to ask a question, feel free to raise your hand or put your question in the chat. I'll be monitoring that. And of course, if you're asking a question, we'd love for you to introduce yourself. The structure of our ECHO session is this welcome and introduction, followed by a didactic presentation, then a case, and then we'll wrap up for the day. What is most exciting about ECHO is that we get to think and talk about real live cases that are going on. And for the purposes of this Transition Learning Collaborative, it might be a case about a specific patient, like you'll hear about today. But it might also be a case about how you're trying to implement something within your own organization and looking for support and other ideas. You can submit a case. It literally should take no more than 5 minutes to do so. And then you have the opportunity to really get insight from a multidisciplinary audience. Next slide. When we do present cases, like we will later today, we're not establishing any provider to patient relationships as part of the ECHO model. So with no further ado, we have today Dr. Patience White, who is a professor emeritus of medicine and pediatrics at George Washington University and the co-director of the federally funded Got Transition National Center for Healthcare Transition in Washington, D.C. Throughout her career, she has been active in academic medicine, clinical care, research, and public policy. Since 2010, as part of her work at Got Transition, she developed the nationally recognized 6 core elements of healthcare transition, including an implementation guide. She provides quality improvement technical assistance on transition and serves on our steering committee and core faculty for this Minnesota Healthcare Transition Learning Collaborative. It has been my great privilege to learn from and work alongside Dr. White. We are all very excited also to offer a process improvement cohort, which you can have the opportunity to also work alongside Dr. White on your own projects. We'll discuss more about that at the end of the session today. In the meantime, I'm thrilled to present Dr. White to share her wealth of experience in putting the healthcare transition evidence into action to develop strategies to smoothly transfer patients from pediatric to adult care. Thank you, patients.
Well, thank you, Tori. I'm overwhelmed with the introduction. I appreciate it. All right, next slide. So today we're going to look quickly at the outcome evidence on healthcare transition and discuss the American Academy of Pediatrics, American Academy of Family Physicians, and the American College of Physicians, sort of joint recent report that's been updated, and the 6 core element approach and tools for pediatric family medicine adult practices. I'll have a brief slide to crosswalk the 6 core elements for the principles of trauma-informed care, but we have wonderful experts here to also make sure that we think about that. And then I'll describe some measurement options as you undertake thinking about doing something in the area of healthcare transition. Next slide. So I love this quick cartoon. This young person has really 2 things that are going on. One is he's looking back and saying, oh my, did I really get prepared here before I'm shot out in this cannon to who knows where? So really, we're thinking about the breadth of transition, sort of not just the preparation for transfer. Next slide. So really, what is it? This is the definition. It's a process of moving from a child to an adult model of healthcare here. You may or may not actually transfer to a new clinician. I think thinking about what an adult model of care is important here. So the goals for the young adult is to improve, obviously, their ability to manage their own health, but also effectively use the healthcare services and to have an organized clinical process in your practice to facilitate this transition. Once again, people tend to think of transition just as transfer or planning alone. It really is a 3-component process. Next slide. I think everybody knows and is probably has patients that have experienced this or experienced them themselves. There's a wealth of evidence, sadly, that without a healthcare transition process, lots of things don't go well. Medical complications, a lot more dissatisfaction, discontinuity of care, and increased hospitalizations and ER use. So this is what we're trying to reverse that's been around for quite a long time. Next slide. So what about the outcome evidence? Everybody says, so what's the evidence here of doing anything here? And there is a lot for a structured transition process, and it statistically significantly improves. This is the triple aim, and we'll show the quadruple aim as well. In population health, there's better adherence to care, there's better experience of care, and better utilization. These are multiple systematic reviews that have shown that we have a lot of evidence that doing a very clear, structured process makes a huge difference. Next slide. Now, to round out the quadruple aim, we just completed a clinician experience survey. We know young people and families think it's better when they have a structured process, but this was a large set of clinicians in 6 different integrated systems. You can see there were pediatric as well as adult providers. And we did it over August of September last year. We got a pretty good response rate considering it was mainly clinicians. And all of them agree that having a healthcare transition process improved what they thought is patient experience, that we know patients also think it's a good idea, and clinician experience. So what was interesting, it was true regardless of clinical role, experience with the process, specialty role, or primary care. So whether you've been working with it for 6 months or 4 years, as was the case, everybody felt that it improved the experience. So now you really have the quadruple aim telling you that a structured process makes a difference. Next slide. So how are things going in Minnesota for young people? This is the National Survey for Children's Health. And this is really parents of young people 12 to 17. And you can see 22.8% of Minnesota youth with special healthcare needs receive transition guidance. You can look below, that's the national performance measure. So we have a lot of opportunity here to make a difference for young people in the planning process. Next slide. So I mentioned the Medical Professional Society's guidance. This has been updated in 2023. It's been built on a few other clinical reports, as you can see, 2011 and then 2018. This guidance targets all youth beginning around the age of 12, and it really has a branching concept for youth with special healthcare needs. It applies in both primary and specialty practices, extends through transfer into the adult sphere, and the recommendations are many, but they suggest focusing on all three aspects of transition and also using a quality improvement approach with a structured process such as the 6 core elements. Next slide. So what about this 6 core element approach? Well, it's not a model of care. You don't just take it and sort of stick it in your clinic. It's a process, sort of a roadmap or clinical pathway that really you're going to work into your clinic. It's been tested in quality improvement learning collaboratives. It's meant to be customized. It's free up our website. Your taxpayers' dollars paid for it. Thank you so much. And the intensity clearly is related to how complex your youth are in your clinic, or what are the social determinants of health, and also with the availability of your resources. So you're not going to do them all. You may do a few when you're undertaking this process. It's been applied now in many different systems and models of care, as you can see here, and all of them incorporated easily the 6 core elements into their processes. Next slide. So this is a summary of the 6 core elements as from the point of view of the roles of the pediatric and adult practices clinicians here. And we're going to spend today mainly on the pediatric side, but they're very similar between what the pediatric folks and the adult clinicians will do around a policy and tracking and monitoring. They differ, obviously, from the pediatric. They're getting them ready to actually transfer in core element 5. And then this follow-up. Whereas on the adult side, we're going to go quickly through 3, 4, and 5 because they're a little bit different as the young person comes into the practice. Next slide. This is just showing you our website so you get familiar. You can download. On the left is these are seen from the point of view of the young person. They're either leaving a practice, staying there and still going through a transition process without changing clinicians. And then the purple on the right is integrating a young person into either family medicine, med peds, or internal medicine adult practice. You can download the whole package. You can get it all in Spanish, and there are full implementation guides for each of these. Next slide. So now let's sort of think together. I'm going to walk through briefly the 6 core elements. And I think to start with, I want you to know that youth and young adults were involved in the development of all of these, along with experts and others that were involved in the process. So all of these 6 core elements actually had youth and young adult involvement, making some choices about this, and really gaining trust a little bit in the process since we really co-developed this whole system with them. So when you go to core element 1, this is the one that actually families thought this was the most important. And it makes sense in the sense that this is really, you're telling them what's coming. And you would obviously think about giving this early on in the process. It really tells about your practice's approach, saying it's going to be over the next 10 years. You want to say when they're leaving the practice as well, if they have to. And you want to, it's offering a transparent approach. Families frequently commented that it was frustrating that even in the same practice, one clinician says, oh, you don't have to go anywhere. And another one in the practice says, oh, you have to leave the practice at age 18. They do talk to each other in the waiting room. So they do figure this out. And it's very important to have a transparent approach for them and really clarify what age 18 means as they get to that age. Now, you want to co-create this clearly with youth and families. And we have some examples available. Core element 2 is important for tracking and monitoring. It keeps you honest. If you've decided what your process is, you want to track whether youth and families receive the tools that you've decided to use. And really for you to say, gee, we're doing a good job. 70, 80% of the young people are receiving what we decided would be a good process in our practice. Core element 3 is getting people ready. Now, you work with young youth and parents to be sure that the readiness assessment you choose or is developed is clear to them. You want to use very reading levels that are low and language that they understand. And it's meant to assess the youth's skills to manage their own health and effectively use healthcare. But I think it's important, no matter what one you choose, and there are a lot out there for subspecialty, from subspecialty societies, as well as as ours up, none of them will predict it, right? So this isn't, if you get a score 100, you're ready to go leave the pediatric practice. It's a process for discussion. It's a way to get people to think about what the differences are between pediatric and adult healthcare, what it means to manage your own health and use healthcare resources reasonably. So it's a sort of plan for skill building education and having people then choose what they'd like to learn and over the next maybe 12 months. So you may do this several times as you're going from age 14 or whenever you start the process to when they leave your practice, somewhere between the ages of 18 and 22. Next slide. Core element 4 is planning. So the readiness assessment really sets this up. You'd like to co-create a set of actions with young people and their families and make sure that the priorities you're setting is something the young person is interested in doing. Now, we all know that young people aren't exactly putting healthcare at the top of their exciting list of things they want to do when they're in high school or at that age. So you want to be sure that you've say why you want to link whatever they're doing to improving their health and to a goal that they find is very interesting. If they're a diabetic and don't take their insulin, you might say, if you really want to go to the prom, you don't want to be sick just before. So give them a short-term goal, because a lot of young people don't have executive functioning that well at that age. You want to also clarify the roles of primary and specialty clinicians in the adult healthcare system. It's very different how the primary care and specialty care interact between pediatric and adult care. Core element 5 is a transfer of care. This is that moment of truth, that warm handoff we talk about. You want to locate a new primary care clinician. I think most people feel that getting the primary care doctor first might be helpful if there's somebody getting a lot of different providers that need to be slowly transitioned, so that the adult provider can help choose or interact with the subspecialty. And I think it's important here that you want to ensure this completion and communication with the adult provider. The more complex, the more you really need to actually get on the phone, perhaps, rather than putting together a medical summary along with the other things for a transfer package. I think joint telehealth with young people that have a lot of complexity or may well have cognitive challenges is a great way for everybody to feel more comfortable as you're moving into a new setting with a new provider. And then finally, transfer completion. Well, the point here is to wrap it up. You really want to be sure the young person made it and that the pediatric practice is willing to care for this young person until they're actually in the care of the adult provider. Families hate to be caught between the two practices if they ran out of their medicines or need something. So you want to be sure that the roles are clear about who's going to take care of the young person. And it's usually the pediatric practice until they actually see the adult provider. Next slide. So I'm switching. If you're an adult provider out there, you also will do one of those policy guides and have a registry. But core element 3 is different because you're planning on orienting the young person into adult practice. So you really want to be sure that if you're a large group, you identify adult providers who are interested in caring for young adults. Not all people are. And so I think it's important that the practice knows who's interested. And then you want to welcome and orient them. The young adults here were very clear about they would like some information in answering frequently asked questions. If you want to know the list that they put together, it's up on our website. But this is very helpful. And you actually can share both this sort of FAQs with pediatric practices so people can look at them before they even get to your practice. Core element 4 is actually bringing them into your practice. You want to be sure you have all the information. I can't tell you how many times as adult provider, I have a young person transition to me and I have no information. It doesn't bode a lot of confidence when I'm saying, well, gee, I didn't hear from your doctor, but I'll get in touch with them. Please tell me about your medical problem or what you're coming here today to see me for. You obviously want to review the key next steps in hopes that that transfer letter said, well, there are a couple of things that weren't wrapped up by the time they left the practice. In your first 2 appointments, it'd be really good if you followed up on those things. Young people aren't the greatest at showing up sometimes to the clinic. So reaching out and trying to connect with them beforehand is often very helpful. Next slide. So then you have these initial visits, and I think it's helpful in a practice to have an agreement on the approach of topics to be covered. If you do too many things at once, young people get sort of turned off. So it's a good way to think about the key things that you should need to tell them about your practice and spread it out over the first couple of visits. We actually have an example of one put together by the young adults. You obviously want to review, update, and share that medical summary. The doctor to be called on that medical summary now is changed to the new adult provider. You want to review the transition readiness assessment, but seeing so many don't get preparation going on in Minnesota, it's likely you're going to actually do a self-care assessment that's available on our website to sort of gauge where they are in becoming health literate and being able to manage their own health here. I think reviewing the roles of the young adult, each provider, and particularly understanding the role of the family. They're there for support, but they aren't necessarily in the clinic when they're over age 18, unless they have medical legal documents. Next slide. So here is just my take a little bit on crossing the principles of trauma-informed care and the 6 core elements. I think the concept here is there's been a lot of empowerment to develop these, and in developing these in your practice. I think that's important. They have lots of choices here about what they want to work on as they're trying to improve their ability to manage their own health and manage the healthcare system. It's meant to have collaboration. The whole point of having a structured healthcare transition process is to have a safe transfer, continuity of care. I think that's crucial here. And then along the way, if you sort of talk with them and plan with families, they're going to trust you more. And if you have a good handoff and really talk about your adult provider in a way to engender trust, things will go much more smoothly. And that's the concept here. So we have obviously experts, and they could go into this in much more detail. Next slide. There are two ways to measure here. I'm about to wrap up. I somehow lost my screen. I have oh, there it is. Sorry. And this is the easiest current assessment of healthcare transition activities. You could do it in your clinic, do it for yourself. You just circle what level are you in each of the core elements. And you can see, for example, on a policy guide, this is the one for a pediatric practice. Everybody's the Wild West on level 1. Everybody's doing their own thing out there. And level 4 is really saying you have one, it's written, you did it with families, you have it out there, everybody receives it. And I think that's really, it gives you a gold post in all of these. So it's a little bit of a teaching as well if you're going to have your whole practice fill it out. Next slide. There's also a sample youth transition feedback survey. The youth said it had to be really quick, very short, as you can see here. Ours is geared for doing the core elements. You may want to customize it if you're not doing all of them or only some of them. But the key point here is overall question, how ready did you feel to move to an adult doctor or other healthcare provider? This is very helpful for you as a pediatric practice to get that feedback. Did it work well? You can ask your adult clinician folks to have them fill it out anonymously and send it back, or you can do it at the last visit, however you want to do it, to get some feedback from some of your youth to understand if the process you've instituted is one that they find helpful. Next slide. You can actually do a feedback survey for clinicians. This is adapted from the medical home feedback survey. This is the one we used on the 6 systems that I presented earlier. So it's also a way for in a managed care or in a large practice after you've instituted to see if your clinicians really found it helpful to institute that kind of structured process. Next slide. So you can find out how to do this. Everybody says, this is great, Dr. White, but how do I go about doing this? So we have how to implement the 6 core elements up on our website. And later in the Echo, I'll really walk through thinking about how you could do it. But it gives you sort of 9 steps to think about in beginning the process. Next slide. So I'll wrap up. Just to remind you, on our website is also some resources for youth and young adults. We have a 1-minute sort of video about what is healthcare transition. There's quizzes for young people, how to put your health information into your iPhone or other phone. So there's a lot of information for youth. And the next slide. There's equally a lot of information for parents. In particular, we have a family healthcare transition toolkit. You can see here, it answers a lot of these questions. So for instance, when should my child and I start to think and talk about transition? What questions can my child and I ask our doctor? How does my role and my child's role change throughout the process? How do I learn if my child needs help with decision making? So there's a lot of tools in this to help families think about answering some of these questions. Next slide. So I want to thank you for your attention. I hope you're not looking like these 2 young people here, either asleep or going, oh my, I don't know how to think about this. But you take small steps. That's the key thing. And I want to thank obviously you for listening and all the patient and families who guided us throughout developing this process. I'll turn it back over to you, Tori.
Well, thank you, patients. That was wonderful. As anticipated, we have about a few minutes here for questions. If anyone has any questions for Dr. White, you can certainly raise your hand or drop them in the chat. So we're giving people a moment. Patients, I was just reflecting on, we've worked on an organization-wide transition policy at our institution, but now it makes me think about, well, I kind of have my own, like we have one within our own department. And how do you keep all of those straight. Balancing that. So something I'll be reflecting on.
Yeah, it's very hard. And the larger the system you work in, the more you should actually have one. And everybody agree on things, because it's very hard for families. If, for instance, in a big system, gastroenterology says everybody leaves at 18 and cardiology says you never leave. And people are then split between two systems, which can be actually rather dangerous for people. You leave it up to patients to decide which institution to go to. So you're right. The larger the institution, the more likely it is you need to have one. And we have some examples of one for whole children's hospitals have the same one. And it's fun. You could actually, instead of writing it down, you could have a little video, which some practices develop, but for when they're young adults do that.
Yeah. And looks like Arjun has a question.
Yeah, a couple questions. First of all, I'm not a clinician, so for context, one, how prescriptive or clear is a clinical transition from a pediatrician to an adult PCP? How clear is it for a I know it's not clear for the member, or for a patient, but how clear is it for a clinician? Like if I go to my child's PCP or pediatrician, like is that my first point of contact, or is there other conversations besides just my pediatrician that I should be having conversations with?
Well, so I hope I'm getting it's a great question. Thank you. When you think about how many families actually got planning for their young person, I mentioned for Minnesota, very few do. So I'm not sure that the clinicians right now, many of them are thinking about this. There's a lot of things going on in practices. And often when they do, the young person is near to the time that they leave the practice if they have to. So answering your question, I'm not sure, since only 22+% actually got it, not a lot of people think about it. But this has been out for a long time. It is recommended by the American Academy of Pediatrics, et cetera. So bringing it to the attention of your practice, you can always say, what is your process? And we actually have a list of questions that you could ask your clinician about it, and then actually say they'll have the opportunity to, you can say, and up on, there is in your field, in your professional society, these guidelines. So you can nudge them along. And really, when we developed these about 5 or 6 years ago, we came out with them for clinicians first. And now we've been working with Family Voices in other areas, so that I think families will actually drive this process the best. You guys, you have the biggest investment. And usually when you ask the question, people go, oh, that's something we should do, and let's plan together. So it's a great question.
Thank you.
Patients, there are several questions in the chat that I think you could answer pretty quickly in the chat. So I'll let you do that. But one may be a little more difficult. So I'm going to ask that, and then we'll go to our case. So given the inherent developmental challenges of adolescence, I'm curious why these protocols start at 12 years and not 10 years as we seek to maximize a child's inherent curiosity. This is a child life specialist.
Right. You could start it at any age. There's no golden thing about 12. It's just very interestingly, there are a couple of studies done where young people were asked about what would they be interested in planning sort of for their future a little bit. And it was pretty not, the 10-year-olds weren't so interested. The 12, 13, and 14-year-olds were very interested. And then, they're lost in adolescence, and they're not so interested about anything other than what's going on in their peer group. These are obviously gross generalizations, but that's where that 12 to 14 has been suggested. Now, some people say you should be talking about transition from the day they're born if they have a very complex, but it's a lot for families to handle. So what you're doing at 12 to 14 is saying, congratulations, you're here. over the next 10 years, we're going to work together for you to move to an adult approach to care, as well as perhaps an adult clinician. So sure, you could start at 10, and some you do. It depends on the young person. But in general, both families and young people thought 12 to 14 was sort of a time to maximize it before people, and some people obviously aren't interested at 14. They're already sort of in that older adolescent mindset. So it's obviously very individual, but when you're trying to make a major change in a practice, you have to start somewhere. So that was why we came up with 12 to 14. And we're really only talking about the process, right? They're not transferring at 12 to 14, which people sort of, whoa, when I start talking, they said, well, they're too young. I said, yes, I agree with you. All you're doing is helping them plan and making everybody see it's a natural progression, like you go to the next grade next year after you've finished one grade. So I hope I've answered that question. It's a great question.
Thanks, Patience. I'll let you type away in the chat to answer those other questions. So next, the goal of Project ECHO is to build a multidisciplinary community to learn from one another. We all come to today's ECHO with a wealth of experience and have knowledge to share to help each other as we start to implement transition projects in our systems and in our lives. Today, you will get a glimpse of what it is like to present a case, and I encourage you to sign up for a case that you have as well. Today, we have Dr. Razan Byrne, a pediatrician at Children's Minnesota Minneapolis Primary Care Clinic, presenting a case. She is dedicated to advocating for quality, equitable healthcare for our most vulnerable pediatric populations in Minnesota. I had the great privilege of being an intern with Dr. Byrne, and am thrilled to get to continue to partner with her in caring for patients and learn from one another as we develop synergistic transition processes at our systems here in the Twin Cities. Welcome, Razan.
Thank you so much, Tori. Yes, just like Tori mentioned, I work at Children's Minnesota. I am one of the pediatricians in our primary care clinic here. And we also have a unique population, which we do service a lot of the Twin Cities or the local community here, but we also serve a larger population across the Twin Cities with more complex medical needs, where they also get their subspecialty care at Children's, and families want to try to keep everything in the same system. So this case kind of highlights that as well. And so on this first slide here, not to overwhelm you, this is more so I met this patient when she in particular was 19 years old, was the first time that I particularly saw her in the clinic. Previously, since she was essentially born, she was seen by the same pediatrician. And so she, now at the time of this case, she's a 20-year-old with Rubinstein-Taybi syndrome, a rare genetic disorder that can present in many different ways, but one of the most unifying diagnoses is an intellectual disability. So this is sort of a summary of, at this point when she's 19, 20 years old, these are the subspecialists who she's still working with directly. So, and then some of the medical history that is popping up and still needs ongoing care. So within the primary care perspective, of course, care coordination, and then of course the fine motor and gross motor coordination difficulties that she has. She has some urinary incontinence and chronic constipation that instead of being followed by those subspecialists anymore, being followed by her primary. Genetics, she has a couple testing things that she's getting done with regard to her Rubinstein-Taybi syndrome and sees her geneticist once a year. She also has a diagnosis of autism spectrum disorder and motor and intellectual delays, and has ongoing therapies within PT, OT, and speech for that. She's also in a transition program through the school district so that she is continuing to receive care from the community side with regard to how to transition into adult living and adult activities of daily living. She also has some bilateral sensorineural hearing loss, so she wears hearing aids and is followed by ENT and audiology. She has sleep apnea, so she uses nightly CPAP and is followed by a sleep specialist. She has polycystic ovarian syndrome and is followed by, at one point in time, both endocrine and OB-GYN in our clinic, but ultimately is really followed mostly by endo at this point. She's also had a couple of years of chronic cough and throat clearing without any real underlying diagnosis, so she's actually being evaluated by our aerodigestive team here at Children's, which has the pulmonologist, the GI specialist, and her ENT doctor looking at the etiology of this chronic cough and throat clearing. She has a history of foramen magnum syndrome and a syrinx. So she had part of her brain that she needed to have some decompression. And so when she was younger, she had a major brain surgery and had a VP shunt in place to help with pressures in her head. So she has that as well. It needs to be followed by neurosurgery. And is an oral eater, but she really does struggle with obesity to the point where she's actually managed by a weight management team as well. And just some additional social history. Her parents are divorced, and her mom is the primary legal guardian for her after she turned 18. And mom is also the one who predominantly brings her into clinic visits, although both parents are very active in her medical care. And so a couple different, if you want to go to the next slide, a couple different touch points for this patient with regard to the attempts at transition planning. So when she was 15, that's when in the documentation, there was written documentation about discussing transition during her visit with her primary care provider. And this is the same primary care provider who has been taking care of her since essentially she was born. And at that visit, the primary care provider wrote down that he had a list of potential adult primary providers who take complex medical patients across the Twin Cities, who he had personally curated and provided to the family as kind of a stepping stone to really start the conversation about like which system should she be in, whether it's with, in the Twin Cities here, we have many different medical systems, and what type of clinic the family would be interested in. And so that's to start that conversation. And then she sees her primary care provider every year. And at her 18-year visit, that was actually the last primary care visit with her PCP. He was retiring 2 weeks after that visit. And so at that visit, that was the time where mom said, I still am not ready for transition. I know we've talked about this for years. I'm not ready to talk about it yet. What do you mean you're going? Although this provider had mentioned that he was going to be retiring the year before, it seemed a sudden surprise for the family. And before that visit, this primary care provider had created this comprehensive, what he called a transition of care document, which is one thing that Patience White had kind of alluded to as part of those 6 core elements of transition planning, and provided it for the family with a comprehensive list of, who her subspecialists were, what were some of the active medical issues, what was her current list of medications, what they talked about at that appointment, contact information from many places, so that the family could have it all in one document. And then he encouraged them to see a new adult provider, and that he would communicate with that adult provider once the family got in contact with him as to who they decided to choose, and that he would have a warm handoff that he would do at that point. And then at 19, this is when she came and she saw me for the first time. And so back at our office, mom had mentioned to me, you know what, I just was not ready for the transition. I heard that you guys can keep seeing patients until they're in their 20s. All the subspecialists who she sees, they all say that even though they're pediatric based, they can see her till she's 24, 25. And I feel like it's very stressful to transition quickly. Like, right now I feel like this sudden stress because she's 19, about to turn 20. And all of her subspecialists said, oh yeah, it's fine. We can see her, we can see her, we can see her. And now suddenly everyone's talking about how to do this transition. And mom's feeling stressed to transition her quickly because she feels like her child's aging out of all of the providers who have taken care of her for decades. So as you can imagine with this patient, there are a couple of things at play here, but really, often these medically complex young adults have multiple transitions that are happening. Particularly at Children's Minnesota, many of the subspecialists who see patients at Children's are only children's subspecialists, and they don't necessarily all refer to adult subspecialists within the same medical system. So I would love to have, for discussion, really talking about how do we navigate these discrepancies when you have subspecialists who are transitioning at different ages and throughout different medical systems within the same area, and if there are any really good insights that we can learn about with regard to that. And then with this patient in particular, it did feel like this family was kind of lost within each of those years that they came into the clinic. There was discussion during the visits with the primary care provider, but there really weren't any resources within our clinic to be able to help with ongoing support aside from an additional visit in the clinic, you know, in terms of care coordinators or anything like that. And without some available supports in a clinic to really help a family, to encourage them to make an appointment with a new clinic or work through how to find an adult provider, how can we encourage and support parents to be more proactive with making such decisions? What other things could we have done in this case or in any cases that you have in your clinics? So I'd like to open it up for some discussion and hear what anybody has to say about any of these topics.
Thanks, Razan. This was great. So, I mean, as you could see here, lots of the 6 core elements, parts of them were put into place. Conversations started early, but still it was difficult. So, interested from the audience, anyone else have similar situations or ideas for Razan?
There's a couple folks with their hands up.
Oh,
Tori.
I can. Oh, there we go. Debbie.
Hi. I just like to say that one thing that I'm looking for here, and that is preeminent, I think, in the minds of parents is, and maybe it's not, maybe it's kind of in their subconscious, but is this the psychological and emotional aspect of transitioning, where you have kind of had a traumatic experience during those pediatric years. You've gotten to know your providers and establish relationships with them, and you've come to a safe place even through traumatic events. And then you're going to make a transition to an entirely what you perceive as a new world. And there is a very significant emotional and psychological aspect to transitioning that I think we need to discuss more. So I know for us in that transition process, it helped to have the psychologist involved in the transition process as well.
Excellent, Debbie. And Alyssa?
Hi, just a couple of comments. Thank you for sharing this discussion. As a disclaimer, I'm not a clinician. I am a quality improvement coach and specialist. A couple of things kind of came to mind. First, I agree what Debbie was saying about the psychology and just the ambivalence and just the anxiety about changing, providers for somebody that, has had longstanding history and relationship with pediatric providers. I think that's important to acknowledge. A couple other innovative things. My first thought was a care coordination care conference, but then I saw your second point about not having a care coordinator. So aside from that, another thing, if the young adult or youth has an IEP or something, it might, if you have a really savvy school nurse or school involvement, it would be interesting to think about writing some goals and planning the transition in the IEP and having some school support too. I think that would be an interesting, thought. And then another idea might be thinking about, and this might be like a soft kind of shift for the family to think about having a visit with pediatrics, then moving to the new adult clinic, and then going back and having maybe even a telemedicine visit with the pediatrics, so you can check in and see how things are going. And again, that might be like a safety net that they have that link back to peds, and to think about that too. And those are just some thoughts.
Thanks, Alyssa. Also in the chat, Bonnie writes, it speaks to the importance of having one plan across a larger system, which I think Razan and I both agree with as well, because I also take care of this patient. But then you get a layer of 2 or in this case, I think there's at least 3 different systems as well, outside of just multiple specialists within one system. And Mary?
Hi, good morning or afternoon, wherever everybody is. I'm in California, and there are multiple layers that we have here. For one, we have, and I'm not sure what it's called in other states, but we have California Children's Services, and it follows children with complex chronic illnesses till age 21. So this young lady would not have to leave her pediatric program until age 21. 19 is the perfect time to begin talking about this transition, because it's going to take a while to find all the specialists that she needs. Certainly for this transition, a huge component in California, and it may well, I would expect in other states as well, it's going to be who's going to pay for her adult care. If it's going to be Medicaid, or here it's called Medi-Cal, then we need to be sure that whoever's going to take her is going to accept her insurance, and we have to find specialists and PCP who's going to be able to accept her in her insurance program. And that would be one of the first areas of focus for us. As far as care coordination, what we're able to do is have care coordination through her managed care plan. If, let's say, she is Medicaid, then we have care coordination through her Medicaid managed care plan. And that's one of our responsibilities, is to be able to provide this kind of transition. In our managed care plan, I'm the pediatric medical director for our managed care plan, and we have a special program specifically for youth like this. It's one of the only ones we know about, but we set it up specifically for youth who kept falling through the cracks. Whereas one of our doctors said they just go over the cliff when they hit 21, and they have nowhere to go. And we've set it up with tertiary care institutions in each of the areas where we work, so that we can set up transition for these youth once they hit 21, and we already have established specialists, so that anytime we have a youth with this many needs, we can already say we have a PCP who will follow you, we have specialists who will follow you. And that's the kind of thing that needs to be in place for our youth with special needs like this, because unfortunately, adult care is not set up to be as collaborative and as warm and huggy in the way we pediatricians are. But yet our youth still have that need. So those are some of the things that we'd want to be sure would be in place to make sure that this transition is smooth. Thank you.
Thanks, Mary. That is an exciting model. Also in the chat, folks are throwing out vocational rehab and the IEP team at school, and utilizing those resources. Julie gives a shout out to school nurses, of which in the state of Minnesota, there is a transition committee of school nurses who are thinking about what is their role as well. I would wonder, Razan, lots of these things about utilizing other resources require time and energy, of which you don't have a care coordinator. So I'm wondering your thoughts on the year-long follow-up. And does your clinic do or think about the follow-up and how frequently you should see a patient? You know, we have very clear guidelines. When a baby's born, you see them 2 weeks, 1 month, 2 months, 4 months, 6 months, multiple times that year. Is there a role of that?
No, that's a great question. I mean, I know in this particular clinic, at the time when she was in her early teens for this patient, they didn't necessarily have a policy for the clinic itself. And then gradually, as patients were aging in their clinic and as they were more complex, and recognizing that a year long is honestly too long to wait with all of the balls that are juggled in the air, and particularly with a family who, even if they are excellent at care management and care coordination and communication with all the subspecialists, to really have them come back to see the quarterback that is the primary care team. So for this particular patient, she didn't necessarily see her previous provider more often than every year after she was like 13 or so. And I think part of that was specifically for the parents who were like, my child is less complex now than they were when they were 5 and 6 and in the ICU all the time and needing many different surgeries. So I think maybe some of that was because of where the family was at, but now we do have a policy within our clinic, within our complex patients, we have some extra scheduled time to be able to have them come back at least every 6 months, so that once a year is the comprehensive visit, but then there's another touch point within 6 months. And for our patients who live further away, that might be telehealth, or for patients who otherwise have difficulty coming to the clinic, they're trained and vented, and transportation, medical transportation can be hard. That we have that as a telehealth option as well, particularly for these sort of discussions and just making sure that there's a touch point in between. And then there's some providers who are finding it that every 3 months for certain patients, or especially if they're tackling one thing at a time and being able to kind of meet parents where they're at, that having them come back every 3 months is actually beneficial. So it kind of depends on the patient.
Wonderful. And there is a rich discussion going on in the chat as well. I agree, insurance plans need to be part of the conversation as well. Utilizing my chart to send reminders and really thinking about systematically, how do we go about doing this sort of transition? I'm so excited. We've had so much conversation. I hope that you will bring this conversation to your own organizations and your peers and continue to talk about what is the role, how do we work together? Sarah put in the chat, is there any professional medical association that's working on developing a group of adult providers interested in taking care of these adults? Yes, we need that. So if there are folks that are interested in exploring more, of course, speak within your own organizations. Wendy Berghorst at the Minnesota Department of Health as our special advisor on transition to adulthood. You can always reach out to me and our transition healthcare learning collaborative team here. We want to work alongside you to help really make a change in Minnesota. So we will just wrap up quick because I want to tell you about a really exciting opportunity. Are the slides showing? Katie, I don't see them, but maybe. So our next session is how do we partner best with youth, young adults, and families for developing healthcare transition. This will be led by Dr. Peter Skull, a pediatrician at the University of Minnesota and researcher, and several sessions coming up. And then this is what I'm most excited about. So we have generously gotten some support from the Minnesota Medical Association and the Copic Medical Foundation to offer 4 very short 6-month quality improvement collaborative learning groups. So this will include 4 different organizations who have a transition project that they are working on implementing. And you will meet with patients, Peggy from the National GOT Transition organization, as well as our QI specialists here at Gillette and myself, and really walk through what is it that you're wanting to do, getting feedback about how you can do it better, learning what already exists so you're not recreating the wheel, so that you can rapidly do your PDSA cycles and really start to be a catalyst for change at your organization. The application is really short. There's a small stipend for participating sites. The application will close in mid to late December. And we will start our sessions next winter and spring, and you'll present a poster at our Healthcare Learning Collaborative Transition Summit scheduled in June of 2024. Otherwise, we will stay on if you have any questions about that. It's all over our website. And here we just welcome you thank you so much for joining us today and having conversations. And we hope that you bring this back to your organization and keep on talking about it, because that's how we're going to make a change for Minnesota youth. On the left there, you will see an evaluation. We welcome your feedback. We want this to be a useful experience for you, so please fill it out. And then on the right, if you have a case like Dr. Byrne did here today, again, it can be about a patient, it can be about a system that you're trying to implement, and you want to get feedback from the group, we would welcome that too. Again, a couple of minutes to fill that out and you're ready to go. Otherwise, we wish you a very happy Monday and great week.
I have one question.
Sure.
Will that application be sent out, or can you send it in an email for the application?
Katie, are we able to do that? Can we send a link out?
Yep, after this session today, I'm going to be sending out an email.
Perfect.
Awesome. Thank you so much.
Yeah, thank you.
Bye-bye.